fibrillation, just focusing on, the diagnosis, how the treatment options are, and what the difference between options, what these options are for you as a patient, and then hopefully a few questions and discussing some points. So atrial fibrillation is essentially an irregular heart rhythm that starts at the top chamber of the heart. And it's essentially where the beat is not smooth or in an organized way, where the heartbeat often becomes irregular and can be too fast. And as a result of that, patients typically feel symptoms of palpitations, shortness of breath, and fatigue. Although some patients have no symptoms, the majority of patients that we would see in our clinics would have symptoms as one of the sort of presenting complaints, essentially. And why it matters is really because the risk of stroke goes up when patients have atrial fibrillation. You probably notice in this crowd, and symptoms can affect daily life. So if you're getting shortness of breath, you're getting fatigued, it can really impact your quality of life. And we know that over the long term, that having atrial fibrillation may affect the heart's pump function. Therefore, especially in patients where there's already a weakness of the heart pump function, atrial fibrillation, where possible, is better treated by trying to convert it back to a normal rhythm. And the method that we use to diagnose it is we do ECGs. And they can either be on a 12-lead ECG, which is a snapshot in time, where it gets done over 2-3 minutes, or you can take home a monitor which stays on for between 24 hours to roughly 2 weeks. But the majority of these is between 24 to 72. So 1 to 3 days where you have this monitoring that identifies that this top chamber is working in a disorganized way that's making your heart faster than it should be. And as a result of that, you may be experiencing the shortness of breath and the fatigue that we've mentioned. And how it's managed varies to some extent, but there are some principles that hold true across the spectrum. And when we look at the UK and the European guidelines, they both emphasize the importance of stroke prevention, which is the main negative sort of impact, and that's why we consider anticoagulation. And secondly, to improve patients' symptoms, so control their symptoms, preventing it from impacting their quality of life. And that's done by, I alluded to it earlier, I mentioned it earlier, stroke prevention is enabling patients where required, which is the vast majority, to be on blood thinners to reduce that stroke down to a baseline population risk, so to a level where they didn't have atrial fibrillation. Secondly, to control symptoms, and that can be done either by reducing the heart rate down, that's something called rate control, where the heart rate is brought down from, let's say as an example, 110 at rest, down to a normal resting heart rate of about 70. Or in some cases, restoring that normal rhythm, taking you out of atrial fibrillation, something called sinus rhythm, which is normal rhythm, sort of restoring rhythm. And that can be done, which I'm going to come on to describe, with tablets or with an interventional procedure. And amongst all of that, atrial fibrillation generally is due to other comorbidities as well. So other health problems can precipitate it. So managing blood pressure, weight, other conditions like sleep apnea or impaired heart function, alcohol excess can impact it, and treating the whole patient is part of this. And ensuring that we review on a regular basis and that we manage this in a sequential way. And the cornerstone of sort of, contemporary medicine, especially in atrial fibrillation, cardiac diseases where it influences several different pathways or conditions, is shared decision making. You go through the options with the patient of, do you want to have rate control versus rhythm control? What the benefits and risks of those are. We're going to come on to explain that a little bit more in a minute, to make a decision together about what the best strategy is. And the cornerstone to it is understanding the patient's risk of stroke. And there are very well validated studies, several studies showing that one of the metrics or one of the parameters that we use is something called a CHAD-VAS2 score, which essentially looks at your comorbidities, your gender, and your age, and determines what your overall risk on an annual basis is if you didn't have any blood thinning medication. And as it shows here, it can be heart failure. This includes, heart failure, high blood pressure, your age, whether you're 65 or over or 75 or over, whether you have diabetes, whether you've had a previous stroke or you have vascular disease, and whether you're male or female. And then if your risk is 2 or above, then we generally consider that to those patients, have a discussion with them about commencing anticoagulation, so blood thinning medication. There were the newer blood thinners, which don't need regular tests or checks of your blood thinning levels, which are called DOACs, or direct oral anticoagulation. And then there are the traditional, more established therapies, or more traditional is a better choice of word, I think, here, which is the warfarin vitamin K antagonists. The majority of patients will be on the newer type of medications, unless there's a reason where it's more advantageous to be on a vitamin K antagonist like warfarin. And what's really important here is the blood thinners lower your risk of stroke, which is really important, but they don't cure or treat the atrial fibrillation in itself. And that's really important to know. But obviously, one of the most significant things that can happen if you have atrial fibrillation is developing stroke, and this reduces that risk. Second component is looking at how we control symptoms. So AF treatment can focus on heart rate control, rhythm control, or both. So I'll go through them one by one. So rate control means we slow the heart rate down so that they ease or actually eliminate your symptoms that you're experiencing. For example, the shortness of breath and the fatigue and the palpitations. And the medications that we have available, there are a few, generally centered around giving beta blockers or calcium channel antagonists, such as diltiazem, which is mentioned here. And this is the first line of therapy for patients who have chronic atrial fibrillation, where it's not in an acute setting. And then the second line of treatment, and sometimes in some patients, it's the first line of treatment, depending on the age, of their symptomology, of their heart pump function. This is something to discuss with your doctor if there's a question mark about you having atrial fibrillation or it's being confirmed, is whether it's rate control or rhythm control. And the rhythm control aims to restore or maintain that normal heart rhythm. That thing I mentioned earlier about being sinus rhythm, that's the normal heart rhythm. And what that does is it restores your heart's conduction pathways to a normal pattern, prohibiting those fast beats coming in, essentially. And this can be done 3 broad ways. The first is cardioversion, where we deliver a controlled electrical current to the heart to realign the electrical function or the pathways so that it works in the normal way. The second is to give medications that do that pharmacologically. And there are several medications that can be used. And then third, for patients who have failed 1 or 2 of the other options for rhythm control, cardioversion and antiarrhythmic medication, we consider something called a catheter ablation, which has become standard of care for this subgroup of patients, where you go on to have intervention to isolate and essentially freeze or prevent those areas producing the extra electrical activity, extra beat, or the AF, from impacting your heart with rhythm and rate. So blood thinners, treatment option number 1, really important, reduce the risk of clot formation in the heart, and that clot then goes up to the brain if it's not treated and causes a stroke. And there's a counterbalance about doing the risk scoring, as I mentioned, for each patient. The higher the risk score, the higher your annual rate or probability of having a stroke. Therefore, the more beneficial the blood thinning medication would be. Second is rate control. So in itself, it doesn't remove the AF, but it can make the symptoms significantly better. And common medications used, as we've mentioned. Third is rhythm control. So that's to get your heart from an irregular rhythm to a more regular rhythm. And that is the treatment of AF, the mainstay of treatment, where you're restoring back to normal rhythm. And we know that in certain patients that this is our preferred option in the vast majority of patients, to try get rhythm control. The exception to this is where patients are known to have atrial fibrillation for a very long time, where we know that rhythm control, whichever way we do that, medications, cardioversion, or an invasive procedure, we know that the success rates are going to be low based on several tests, like your echocardiogram showing that the chambers have enlarged, or previously failed procedures where we tried to rhythm control. So in those cases, we tend to go for the rate control option, but rhythm control remains the mainstay of treatment where we know that the success rates are high. In catheter ablation, if you see these two pictures, if you look at A, for example, you can see that there are these red dots. And if you imagine that the central port is the central area around the dots is where the abnormal rhythm's coming from, what you do is you isolate that area electrically, so that it prevents extra beats from coming in, therefore enabling or preferencing your normal heart's conduction pathway to get normal beats. And this is a procedure that's performed across the UK, across Europe, and has become one of the mainstays of treating atrial fibrillation to restore rhythm control, which we know is really beneficial in a significant proportion of patients. This just outlines that again. Cardioversion, it's a way it resets the heart into a normal rhythm, and with medications on top, the aim is that you maintain your normal rhythm, but it's not as successful as the specialist procedure, the ablation, because that really treats it by isolating those areas that are causing the abnormal rhythm. In some cases, patients can have more than one of these ablation procedures, or the cardioversion, in fact, where different medications may be tried in conjunction with these procedures to make it the success rates higher. And having the procedure doesn't mean that you can necessarily come off your anticoagulation, your blood thinning medication, because it's really important that you follow the guidance of the doctor who's managing you, the cardiologist, because fundamentally there's an individualized patient risk profile and your risk regarding stroke that we may, even if you've had a successful procedure, want to continue on some blood thinning medication, at least for a short period of time after the procedure, to make sure that you have sustained a normal rhythm, essentially. So we don't want to inadvertently stop the medication early and then increase your risk of stroke, is I guess what I'm trying to say. And the holistic piece of this, when we look at all the others, there's a bit of overlap on the slide, I do apologize, but when we look at managing everything, what's really important is that we manage blood pressure, healthy weight, assessing that there's no sleep apnea. These are things that we know contribute to either a higher risk of stroke if you have atrial fibrillation, or in and of themselves, the risk factors that can bring back or cause atrial fibrillation. So continuing with diabetes, alcohol excess, staying active, not smoking, and having a healthy diet. All of these things are the cornerstones of sort of cardiology and how we treat patients, but really important in conditions such as AF and, for example, coronary artery disease, where there are several things at play. It's a multifactorial condition, a sort of faceted approach to managing it. And follow-up, so usually it's a long-term condition, so review and reassessment are important. Even if you've had successful treatment, it's really important that we monitor patients on a regular basis, whether that's 6 monthly or annually, depending on several circumstances will dictate that. At follow-up, we check symptoms and quality of life, review that heart rhythm and rate, review your risk of stroke and bleeding, check medications, make a plan together, essentially. And I guess the main things to be aware of is, if you develop any significant change, for example, symptoms of stroke, chest pain, breathlessness that's suddenly come on, then you need to, seek urgent medical attention. The more common is if your palpitations get worse, or you're having problems with your medication, you've missed your anticoagulation, is just to contact your team so that they can guide you as to how best to manage it. One of the things that typically comes up is you're on blood thinning medication, but you need to have either a small invasive procedure or dental work. What's the best way to manage that situation? It really depends what dental procedure you're having. And it's something that, we regularly sort of, a question that we regularly answer. And lastly, I think the take homes are, AF is common and treatable. So it's approximately 2 to 4% of the general population have it. After you get to the age of 65 or above, it's 1 in 20, so about 5% of the population. And that goes up if you look at age increments. So if you go to 75 and 80. Stroke prevention is central goal of care, because that's one of the, the worst possible outcomes. And it's something that we really have a lot of evidence of how to treat and how to understand which patients have a higher risk. So it really is a cornerstone. And then the treatment, whether it's rate control or rhythm control to manage symptoms and restore normal rhythm, will be decided together with your medical team. And then managing the other secondary sort of cardiovascular and lifestyle factors that may influence, for example, blood pressure, weight, as we mentioned. And I think one of the things to do is, is to bring questions. And, I hope these slides, which I think will be shared after this, provide a little bit of information to for the next time you go to see your doctor, or if you've been diagnosed, to go through these important points, which they will do anyway. But if you start to think about them before you go for your consultation, it will only make sure that you enable you to feel that you're more informed as a result of that. For example, some of the things are, what's my risk of stroke? Considering that before and speaking to your clinician about it. Do I need blood thinners? What's the management strategy? And what can I do myself to help? Because I think the main points maybe to take away from this that you can use in your consultations. Thank you.
That's great. Thank you so much. I'm going to open up the chat box now for anyone who has got questions. Please feel free to put them into the chat box, and then I can read them out and then we can have some answers.
I'll stop sharing. Equally, you're more than welcome to ask in person if that's easier for you. There's only a few of us on the call, so.
Everyone is currently muted, so if you do have a question, please feel free to unmute yourself so we can make sure we hear you.
Whereabouts is the chat box?
That's okay. You can just ask from there if it's easiest.
Yeah. In the old days, I don't know if these things still are used, but I remember people talking about pacemakers. Are they a thing of the past, or is that the catheter thing that you're talking about?
Yeah, so it's interesting because so I graduated about 15 years ago or so. And I historically, there has been cases where at the early days of atrial fibrillation, one of the ways to treat it was there is a tissue called the AV node that enables the top of the heart to communicate with the bottom of the heart. And what they used to do is they used to freeze or disable that communication between the top and the heart and put a pacemaker in. And that was one of the treatments for atrial fibrillation, because you could have a controlled, regular heartbeat from the pacemaker. But what we know is that in patients who are pace independent, which would be the case where the pacemaker acts for every single beat, that in itself is not good as well. It causes problems with the heart's pump function over a period of time. So it's definitely not common practice or contemporary care for atrial fibrillation or management at the moment. And it hasn't been for a while. But historically, there are cases where that has been done, and it may have preceded the ablation procedures. Before they became mainstay of how we manage it, it may have been that pacemakers were used. Does that answer your question, Philip?
Yes, sorry, I was giving other people a chance to get in because I've got more than one.
No problem.
So I tend to talk too much and it shut me up. I mean, my problem has been that I was feeling, I felt didn't feel all that brilliant while I was having AF. And I had it while I was with a retired GP mate of mine who said, Philip, you've got to go and get sorted out. The only trouble is that I'm struggling with my GP, and my GP's doing it. I'm now under consultant to find the best combination of drugs. Fortunately, they've done enough tests to say that there doesn't seem to be any obvious major problem with my heart. So they're trying me off, taking me off the beta blocker, because I found that reduced my energy by about 75%. My normal resting heartbeat was about just above 60. And then when I went on the beta blockers, it was dropping me down to feet. And there were other times when I was feeling quite unwell. Well, it dropped below several points below 50. I was down to 48, which isn't good. So they're trying something else. So yeah, from my point of view, I'm feeling worse now. They put me on the tablets than what I was before.
Yeah, I mean, it's a very good point that you make, because fundamentally, we know that the medications work the vast majority of patients, and they work well they actually improve symptoms significantly, but not everyone's the same. And as you have experienced, we commence a medication. The beta blockers are the mainstay of treatment. They're actually used as probably the most common medication used in atrial fibrillation. Unfortunately, in your case, it dropped your heart rate to a level where it made you feel worse. The good thing is it's been identified, and there's options for different, medications that can be trialed, which I presume is what my colleagues are in the process of doing.
Yeah.
But yeah, it does happen. And also what can also happen is it can change over time. And that's what that review component is quite important. So you being on a medication, or a patient being on a medication at one time point where it works well, doesn't mean it's going to continue to work well. And that review process means that you can identify issues a bit earlier and either increase the dose or change the medication depending on the situation. Because your heart over time changes if you've got atrial fibrillation, and the rate of that change varies between individuals, and that may necessitate changing of management strategy.
Thank you.
We do have a question in the chat box that does say, is atrial fibrillation hereditary? Might my children be at risk?
Yeah, so the vast majority, it's a great question. And I think there's been a lot of studies looking at this, but the simplest answer is no. The risk of your children getting it is not clear because you've had it, unless you have a or any individual has a cardiomyopathy. What that means is where there's it's a very distinct condition that you would have heard about and your doctors would have identified on echo. So for routine or standard atrial fibrillation that's not caused by something else, which what a cardiomyopathy would be as an example, then it's unlikely that your children will have it as a result of you having it.
That's great, thank you. Do we have any other questions? No? Perfect. Natalie, were there any other questions from patients that you received prior to this?
One was around the other one. I just remember people asking at the hypertension one around whether this is a lifelong thing and therefore need to continue forever. So whilst it hasn't specifically been asked, maybe just I can ask that here. So once someone receives a diagnosis of AF, is that a forever thing and therefore to keep on all the time? Because we've been doing some outreach work with our hypertension project, and I've come across a few people who've started taking medication to lower their blood pressure. It's then lowered and they think great, and then they stop, and it's only then when they get checked again do they realise, oh crikey, I'm high again, maybe I need to go on this forever. So just in terms of the education of how long is this for?
Yeah, I mean, so hypertension in particular is very prone to that because you have no symptoms, and patients, it's picked up generally incidentally, and patients unfortunately get treated and they continue to have no symptoms, the vast majority, so they discontinue in some cases their medications until it gets checked again. Atrial fibrillation, there are two broad categories. There's atrial fibrillation that can occur as a result of an acute episode. For example, if you have a chest infection, that can precipitate your heart going into this irregular rhythm. In those situations, then it doesn't have to be lifelong, and it tends not to be in the vast majority of cases, because there's a clear precipitant. You've been unwell, and as a result of that, your heart coping mechanism has flipped you into this irregular rhythm, and then it's back to normal afterwards, whether with treatment or without. Then the second group, which is the larger group, is we have chronic atrial fibrillation. And if you have chronic atrial fibrillation where it's not due to something else like the infection, as the example I've given, then if you have rhythm control where you may have had an ablation procedure, then we've got you back to normal rhythm, but you should still get reviews regularly to make sure that you stay in a normal rhythm. And if you are in a normal rhythm, it may be that you can come off the medications. For example, the blood thinning medications. And that's very patient specific. If you're remaining in something called persistent atrial fibrillation, where those options were unsuccessful, the catheter ablation, or the drugs haven't been able, the medication haven't been able to revert you back into a normal rhythm, then it's really important that you stay on the blood thinning medication and the medication to slow your heart rate down. To bring it back together, I think if you have chronic, where there's no clear trigger, it's a lifelong condition, and it needs to be monitored on a regular basis, whether that's on an annual basis or more frequently. And that's to ensure that there's been no progression or no recurrence, even if it's been successfully treated at one time point.
Lovely. Thank you for clarifying that.
Oh, Philip, I think you're muted.
Two bigger thumbs. When you say successful, do you mean a complete elimination of AF or just infrequent?
Yeah, so that's a great question, and it's complete elimination. So there are the success rates of an ablation procedure vary on several factors, but overall, there's about an 80% success rate of eliminating the atrial fibrillation and patients being maintained in a normal rhythm after an ablation or multiple ablation procedures. And that means that over the long term, your heart is in a normal rhythm and your risk of stroke is down to is lower than it was if you did have atrial fibrillation. But obviously things can change over time, and that's why the annual checkup is important, whereby you can have recurrence. Because if you've had AF once, there's a higher probability that someone who's never had it, that you'll have it again. It's true for most conditions in life, if you've had it once before. So the answer to your question is it's complete treatment. And in that scenario, it's still important to have regular checkups, regular meaning, annually at least, to make sure that you remain in a normal rhythm.
Right. I mean, I'll bring this up in my review that's coming up shortly with my GP, but it's good to put it into context for me because he changed the drug and I had an episode just after I started them, and in fact, relatively recently. I don't think you can answer the next question, and that is, I've heard differing advice from GPs within this practice and about how long one should be having an AF before going to A&E, because you may not be able to answer this, but and was told if it goes on for more than, by one doctor, if it goes on for more than 2 hours, you should go. However, given what it's like at one of our local hospitals here, where you're likely to sit there for 4 or more hours before anybody's likely to look at you, having experienced that, by that time the AF may well be over, and one is reluctant to put oneself through that. But what is the guidelines?
Yeah, so I think it varies. There are some things that clearly require you to go in. So it was in one of my slides. There are some red flags. So if you become acutely short of breath, or you feel lightheaded or dizzy, or you have chest pain, then it's important that you go straight to A&E. But if you are, I presume you have plasmatic atrial fibrillation, it comes and goes from what you're describing.
Yes.
Is that right? Yeah. If
Yeah.
you have plasmatic atrial fibrillation, you know what your typical period is where you have an AF flare up, or it comes in and out and it lasts for an hour, then I think if you have any of those red flags, you go straight in. If you don't have those red flags, then it's knowing that you've got AF and normally it resolves within an hour for you. I'm making that example up.
Yeah.
And if it goes on beyond that, then it's worth considering going in. The other thing is, if you feel unwell for any other reason, the atrial fibrillation might be as a result of you having an infection, as I mentioned as one of the earlier points. So it's quite nuanced, unfortunately, and that's probably why my colleagues in the practice have given you different opinions, because there is no absolute and it's very individualized, but there are clearly red flags. If any of those happen, the chest pain, shortness of breath, feeling lightheaded, or actually passing out, you must go in, or feeling generally unwell. But if it's that you have pulmonary fibrillation and you've had a period where the AF came on, but you feel completely fine with no symptoms other than the palpitation, and you're already anticoagulated, for example, then I think that, and some patients also have a pill in pocket strategy that they take when the AF comes on. You take those tablets and
Sorry,
see what the response.
Sorry, what was that you just said? What strategy?
A pill in pocket strategy. So that's what some of my colleagues, where you have atrial fibrillation and you have it comes in and out, where when it comes on, there's an option to take a tablet which can revert you back to sinus rhythm.
Ah, okay. I'll discuss that with my GP.
Yeah, it depends on how frequently it happens. As I mentioned, there's so many different variations and it's very individualized, but that's probably where the miscommunication or different communication that's come from my colleagues. And but if you're on a regular beta blocker, that's normally quite effective. But yeah, it's worth discussing, absolutely.
I'm not on a regular beta blocker, but we won't go into that.
Yeah, you didn't mention it earlier. Yeah,
they moved me off because of the tiredness onto this other one, which is it dissipates over a period of time. Is it to do with calcium? I've forgotten. But never mind.
Diltiazem, verapamil?
I think that's it. Yeah.
Yeah.
But anyway, you've given me food to discussion anyway, the GP. Thank you.
Good. I'm happy to hear that. You're welcome.
Perfect. Have we got any other questions? No? Okay. That's great. Well, thank you so much for your time today, all of you. I really appreciate it. I'll make sure the recording is sent over to the practice. If you do want any photos of the slides with sort of the red flag warnings of when to go to hospital or when to be seen, you'll have access to all of that there as well, and our contact details. But thank you very much, all of you, for attending, and we'll get that sent over.
Thank you very much for all that you've done setting it up and the advice.
Great work, Emma. Thank you as well. Thank you, everyone. Take care.
Thank you all. Bye.
Bye.